Hello, everybody. My name is Richard Bauer. I'm a oral and maxillofacial surgeon at the University of Pittsburgh. And today we're going to be talking about one of my cases for reconstruction of the anterior maxilla. So the situation is an 18-year-old female that was congenitally missing a tooth number 10. She had previous surgeries done at that site that involved guided bone regeneration and implant placement. Ultimately, the implant had failed, was removed, and the graft was attempted to be redone at that point. When we evaluate this patient's risk profile, she does have high aesthetic concerns, and there are issues with amount of bone availability, both in a ridge width and height aspect. Ultimately, we'll have a two-phased approach. We will graft for increase in bone volume, and secondarily have implant placement with immediate provisionalization. There's a component of cortico and cancellous bone associated with this harvested Ramal graft. This is from the patient's left mandible. Now you can see the Ramal graft in position in the patient's maxilla at the edentulous site 10. In this patient, we elevated the palatal tissue, and I've used BioBrief collagen to bulk out the palatal aspect. I like to combine BioBrief and the autogenous harvest that I previously mentioned and fill in the junction of the Ramal graft and native bone. We want to maximize the soft tissue response. And for this, I really like the mucograft matrix. There was a vertical release done posteriorly. It's a curvilinear beveled release extending from the releasing that periosteum at the base of the flap really provides a tension-free closure. So now we've advanced approximately 5 months. You can see that the hardware from the Ramal graft fixation has been removed. We have an excellent subperiosteal elevation. There's excellent transition across the bone grafting site with excellent integration of our graft. The implant driver still in place at the platform level just to show emergence. And here is a postoperative panoramic x-ray. This is immediately following the removal of the fixation screws. And here we have the patient at the 1 week postoperative follow-up. Adequate hard tissue reconstruction is really important. We need to pay attention to the soft tissue manipulation as well. Utilizing the BioBrief at the periphery of the onlay graft is, I think, an essential component in order to transition the onlay graft appropriately and give optimal aesthetic recontouring. The mucograft in this case has really allowed us to maximize our soft tissue profile at the implant site and provide us something to work with during the transitional and recontouring phase once the implant has been placed. A few keys and instruments that I really think are pivotal to gaining the outcomes that we had set. Some of the biomaterials that I find that just absolutely cannot be replaced for this case are our BioBrief collagen and mucograft. A combination of these with the patient's autogenous bone have really led to significant site regeneration. Again, my name is Dr. Richard Bauer. I really appreciate you taking the time to review this case with me. Thank you so much.